Hi, today I'd like to talk about thyroid disorders in pediatric patients. So this is the third video of the video lecture series for the academic half day. So for this video, we will review it on the session on the April 29th. So I hope you have a chance to review it before the session. So first, I'd like to go back to the hypothalamic pituitary thyroid axis, which is the concept that we talked about in pubertal session, and we're going to be using it for the other two sessions as well. So in this situation or this axis, the hypothalamus secretes TRH, which is thyrotropin releasing hormones, which then binds to thyrotrope in pituitary gland, which would then secrete TSH, which is a thyroid stimulating hormone. TSH would then bind to thyroid gland to induce the production of thyroid hormones, mostly T4 and T3. Thyroid hormones will then bind to peripheral organs and sends the feedback signal back to the hypothalamus and pituitary, completing the feedback loop. So thyroid hormones is actually a protein hormone, but its receptor is a nuclear receptor similar to steroid hormone receptors. This is the only protein hormones that binds to a nuclear receptor. And thyroid hormone receptors exist in almost every organ, and making it one of the most important hormones to control growth and metabolism. So for thyroid function tests, it is one of the most common hormone tests in endocrinology. So many of you have written or have ordered thyroid function tests. So which hormone should we order? So the hormone that we should be order is free T4 and TSH. So free T4 is the best indicator of the thyroid gland function. And when you write free T4 and TSH, you're actually testing the hypothalamic pituitary axis, right? Because TSH is a pituitary hormone. So you're assessing the feedback loop. So why free T4 over total T4? Because thyroid hormone is bound to thyroid binding globulin, or TBG. So the total T4 measures bound and unbound forms. So the total T4 level can be affected by the level of TBG. So in a patient that has elevated TBG, such as those that are taking OCPs, TBG can be elevated, causing a falsely elevated total T4. In contrast, TBG can be low in many conditions, including a genetic condition called TBG deficiency. In that situation, your total T4 will be falsely low. So when we talked about hypothyroidism, we divided into primary or secondary, similar to other hormone systems. So secondary hypothyroidism, we often call it central. But for primary hypothyroidism, the problem is at the thyroid gland. So the thyroid gland making insufficient amount of thyroid hormones. So this caused a positive feedback loop to hypothalamus and pituitary, which then raised the level of TSH. So in primary hypothyroidism, the thyroid function abnormalities would be low thyroid hormones and elevated TSH. So what are the etiologies of primary hypothyroidism? So there are 5 main categories. One is congenital, right, which is caused by thyroidogenesis or ectopic thyroid gland, or infection, such as viral or bacterial infection. Trauma, such as patient that had thyroidectomy. Autoimmunity, which many of you are familiar with, which is Hashimoto's thyroiditis, which is probably the most common cause of primary hypothyroidism in children. Or toxic substance, such as iodine or seizure medications, or lithium. So for central hypothyroidism or secondary hypothyroidism, the problem is at either hypothalamus or pituitary. We are not able to distinguish whether is this a hypothalamus or pituitary problem. So we often group them together as a central hypothyroidism. So in this condition, the subnormal TSH level then cause a subnormal thyroid hormones, right? So in central hypothyroidism, the TFT's abnormality that you'll see is a low thyroid hormone with low to normal TSH. TSH can be normal, right? But in this situation, we call it inappropriately normal for the low thyroid hormone levels, right? So that's a central hypothyroidism. So there are three main categories that for the etiologies for central hypothyroidism, such as congenital, which is hypopituitarism. So you can have patients that have congenital hypopituitarism, or patient with brain surgery causing hypopituitarism. Trauma, such as I mentioned, brain surgery or cranial radiation that directly impair the pituitary function, or certain medications such as dopamine infusion or anti-epileptic drugs itself. So let's talk about thyroid disorders in newborns. So as you all know, every state screens for congenital hypothyroidism. So the test that was designed is designed to screen for elevated TSH level. So this test would not pick up central hypothyroidism in newborn. However, by statistics, congenital hypothyroidism is almost always caused by primary hypothyroidism, right? Like I mentioned before, it's either ectopic thyroid gland or thyroid agenesis, right? So when you talked about congenital hypothyroidism, it almost always refers to primary hypothyroidism. So for the newborn screening, if you identify a patient with congenital hypothyroidism, as I said earlier, the most common cause is ectopic thyroid gland or thyroid agenesis. So in this condition, the patient will require thyroid replacement lifelong. Now, it can also be caused by transmission of maternal antibodies, which cause a transient hypothyroidism. And many false positive results, especially if it's done before 48 hours, right? This is caused by physiologic surge of TSH. It can go up into the hundreds range. So make sure that when you receive a newborn screening result, check the time that the specimen was collected. Another condition that many of you have already encountered, which is called subclinical hypothyroidism or compensated hypothyroidism. So the abnormal TFT that you'll see is a normal free T4, which is slight elevation of TSH, right? So most cases do not require medical treatment unless the TSH level is extremely elevated. Right? And for the cause, it's very similar to primary hypothyroidism, right? So it can be, the most common is autoimmune, which is Hashimoto thyroiditis, or medications such as valproic acid, or it could be result of a spurious test. So another condition that can be seen in patients who are intensive care unit, it's called sick euthyroid syndrome or non-thyroidal illness. So it is caused by a reduction in thyroid hormone production during the time of critical illness. Right? So the body tried to preserve the metabolism, so it reduced the production of thyroid hormones. And also decreased the peripheral conversion of T4 to T3, right? So T3 is actually an active hormone. In this situation, the T4 gets deactivated by converted to reverse T3, which is an inactive hormone. Right? So the thyroid function test will look like central hypothyroidism. Right? So you often see a low T4 with normal to low TSH. So how do we distinguish between the two? We go by history again. Right? So if you have a patient that is critically ill in the intensive care unit, we often suspect that this could be due to sick euthyroid rather than central hypothyroidism. Now, the opposite side of the hypothyroidism, which is hyperthyroidism. So the most common cause of hyperthyroidism is Graves' disease, right? It's considered a primary hyperthyroidism. Why? Because it's an autonomous production of thyroid hormones by the thyroid gland. It is caused by the antibody to the TSH receptor that's called TSI, right? So the gland can produce thyroid hormones due to the induction by the antibodies, right? So when you order the thyroid function test, you will see an elevated T4 and T3 and very suppressed TSH level. And many patients have goiter. So goiter itself describe an enlargement of thyroid gland, right? It doesn't tell you the function of the thyroid gland. It can be seen in hypothyroidism, such as patient with severe primary hypothyroidism. TSH levels is very elevated and it can stimulate the enlargement of thyroid gland. Or in hyperthyroidism, such as Graves' disease, which is stimulated by the antibodies to the TSH receptor, causing the enlargement of thyroid gland. So I think that it's all that I want to review for now. We're going to be reviewing some cases during the academic half day. So I hope, thank you for listening, and I hope you enjoy this video.